GR3 Psychiatry Department. I'm going to present my talk on topic dementia today. To begin with, content of the talk will be a brief discussion about introduction about dementia, and then mild cognitive impairment, major causes of dementia, and then Alzheimer's disease, vascular dementia, Lewy body dementias, frontotemporal dementia, mixed dementia treatment, behavioral symptoms of dementia and its treatment. Actually, what is dementia? It is cognitive and neuropsychiatric symptoms. Those are severe enough to impair patients' ability to perform day-to-day activities. These causes the dementia and including these symptoms, they causes definite decline in the patient's previous ability of functioning. What are the common symptoms of dementia? It involves the cognitive domain in which there is a distortion of memory, distortion of attention, concentration, orientation, comprehension, and then like abstract ability is distorted in this patient's. And then there is language impairment, communication dysfunction, and in the later stage there is dysfunction of the biological system also, like there is disturbed sleep, appetite, and behavioral symptoms will also occur as the disease progresses. Now, what is mild cognitive impairment? It is often a precursor of dementia, but it itself is not a dementia. Instead, mild cognitive impairment represents only mild cognitive decline. To say that there is not a it will not affect significantly patient's ability of day-to-day activity. Not all patients with the mild cognitive impairment will develop dementia in future. Elderly people, they will have basic four common symptoms, subjective complaint of in cognitive domain. And it will be like they will be having difficulty in remembering the names, remembering the exact word, or remembering where they have kept the things, or in concentrating in comparison to their functioning of last 5 to 10 years. When such complaints occur in absence of any neuropsychiatric disorder, like there is no neurotic disorder, there is no psychotic disorder, or there is no any sleep wake disturbance or any ADHD, then mild cognitive impairment is diagnosed. At this stage, it is not possible to determine whether the patient with mild cognitive impairment will further will progress to Alzheimer's disease or not. Only on clinical basis, without any biomarkers, studies have revealed that about 6%, between 6 to 5% of patients with MCI will convert to dementia in 1 year. And in 5 years, there will be 50% of patients, those who will be progressing from mild cognitive impairment to Alzheimer's disease. And after 10 years, or in the autopsy of the patient's brain in postmortem studies, it has been seen that patients, those who had MCI, there were near about 80% who developed Alzheimer's disease. So MCI is not always a prodrome of dementia, and reversible and treatable causes of MCI, as I told, that mood disorders or any sleep wake disturbances, if those are taken care of, they should be taken care of and treated properly. That can be reversible. MCI can be reversible in that case. What are the four major causes of dementia? As you all know, it is Alzheimer's disease, vascular dementia, Lewy body dementia, frontotemporal dementia. To begin with, Alzheimer's disease, this is the most common form of dementia, and it is most devastating disorder with profound consequences on patient, caretaker, and on economical basis. It is progressive, and there is substantial neuronal destruction in this. The loss of neuron is so profound that even though we can see the atrophy or neuronal damage with the naked eyes in the post-mortem examination of the brain. What are the three pathological hallmarks of Alzheimer's disease? To begin with, it is first one is amyloid beta, which aggregates to form the plaques, and the second in number is neurofibrillary tangle, which is formed by the hyperphosphorylation of the tau protein. And the third major pathological hallmark, as you all see in this picture, this is picture taken in the postmortem examination of the Alzheimer disease patient. Healthy brain you can see on the left side, and if you compare the healthy brain with patient with Alzheimer disease, there is significant atrophy. There is loss of neuronal damage is clearly visible, that there is shrinking of the uh, brain, and there is atrophy of cortical atrophy is which is more prominent. Now this picture, it depicts this picture has been taken in patients, living patients with fluorodeoxyglucose positron emission tomography. This picture shows us the use of glucose metabolism by the brain. So this yellow color and this orange color, this depicts that the healthy brain, the normal person, there is a good amount of glucose metabolism, means neurons are viable there. As this color, there is decrease in yellow color and orange color in the second picture, that is mild cognitive impairment. As you see that more of green part on the posterior side, that indicates that the glucose metabolism has decreased, which is an indication of the neuronal damage. And as we go to the third picture, that is Alzheimer disease. This green color then converts to blue color. That is total loss of neuronal damage, most on the posterior side, that is temporoparietal region. This fluorodeoxyglucose PET scan it shows the neuronal loss in the living patient, though it is informative, but this is not a diagnostic approach. Now, if we take MRI of the living patient who is suffering from Alzheimer disease, there are visible changes in that. Picture A will, with the circles is showing that purple circles, hippocampal atrophy, which is the main area which is responsible for the memory function. And there is second picture is showing ventricular enlargement. And the third picture, which is highlighted by the blue lines on the outside, that is showing cortical atrophy. These are all the findings of the neuronal degeneration in the Alzheimer disease. MRI is also informative, but it is not diagnostic. Mild patient with mild Alzheimer disease will have 20 to 30% of loss of cortex volume, 15 to 20% of 25% of hippocampal volume loss, and by the time patient exhibit the symptoms, uh, even with mild signs of dementia, there is progressive and irreversible loss of neuronal loss. Uh, Features of Alzheimer disease, that as you all know, that is memory dysfunction, and then there will be impaired higher mental functions, like memory will be distorted in the patient, and then attention concentration will be distorted, language impairment, and abstract ability, communication skills, problem solving capability of the patient. In the later stage, as the neuronal damage progress, there will be biological system involvement, sleep appetite disturbance, and in the last stage there will be with this there will be accompanying behavioral symptoms also. There can be psychotic symptoms or agitation, and these symptoms will come because during that stage there will be further neuronal loss, which will involve the specific circuits of those functions. Like psychotic symptoms, there will be involvement of mesolimbic pathway. Motor, there will be involvement of the motor circuit also. Now, Alzheimer disease pathology. The most famous hypothesis in Alzheimer disease is amyloid cascade hypothesis. According to this hypothesis, Alzheimer disease occurs due to accumulation of the toxic amyloid beta form into plaques. And the second one is hyperphosphorylation of the tau protein, which results in the formation of neurofibrillary tangles. And these, both the changes, they result in synaptic dysfunction, ultimately neuron loss with the memory and dementia decline. Importance of knowing this amyloid cascade is that if we understand this cascade, it will help us to to find out the early intervention for the treatment, because when patient comes with the clinical manifestation, during that time there is a quite significant loss of the neuron, and that neuronal degeneration itself is a irreversible process. So that is the importance that we should be aware about this. Amyloid beta could be prevented from forming, aggregating, and creating plaques and tangles. Alzheimer disease would be prevented, halted, or even reversed. Now, from where this amyloid beta comes? Amyloid beta it comes from the amyloid precursor protein. There are two ways in which amyloid precursor protein is cleavaged, like it's being cut, made into short form of peptides. There are two ways. One is amyloidogenic pathway, and the other one is non-amyloidogenic pathway. In amyloidogenic pathway, like in this picture, first picture is showing us the amyloid precursor protein. To talk about first about non-amyloidogenic pathway, in this longer protein is cut in between where amyloid beta itself is placed. This is done by the alpha secretase. So alpha secretase is an enzyme which protects the development of or decreases the formation of toxic amyloid plaque, toxic amyloid beta. In amyloidogenic pathway, the cleavage occurs at two sites, one side by beta secretase and the other side by gamma secretase. This is the pathway which is responsible for the formation of the amyloid beta, right? And further, gamma secretase will cleavage this amyloid beta into different isoforms. That will be shown in next slides. And out of that isoforms, amyloid beta 42 is the most toxigenic. Now the question here arises that is amyloid beta formation normal? That normally क्या ये body में बनता है brain में? There is no clear explanation for this, but till now what has been mentioned according to the studies is that uh, there are multiple genes involved. There is mutation of multiple genes in the development of the Alzheimer disease, right? So those genes, they play a role with this. Means those mutations, they will make the patient more prone that there will be more functioning of the amyloidogenic pathway in which gamma secretase will be more active, which will lead to more formation of amyloid beta, right? Or in non-amyloidogenic pathway, amyloid precursor protein is cleaved by an enzyme alpha secretase directly into portion where amyloid beta sits. Processing of amyloid precursor protein by alpha secretase precludes. That means it decreases the production of amyloid beta. In amyloidogenic pathway, as I told, that the precursor protein is cleaved by beta secretase and gamma secretase. These are the amyloid beta isoforms. Amyloid beta, which has been cleaved by beta secretase and gamma secretase, is further cut down by gamma secretase in smaller peptides containing amino acid from 38 to 43. So amyloid beta 40 is the most common isoform, but it is less prone to aggregation. Amyloid beta 42 is less common isoform, but it is more prone to aggregation. And amyloid beta 43, it is a rare isoform, but it is also more prone for the aggregation. The most toxic one among them is amyloid beta 42. As same slide says the same thing, that gamma secretase further cuts amyloid beta precursor protein into shorter peptides. Now, the last line, mutation in several genes is associated with Alzheimer disease, lead to increased processing of amyloid precursor protein via the amyloidogenic pathway, supporting the amyloid cascade hypothesis. What are the other associated genes which are involved or which increases the processing? There is one more genetic factor, mutation of that is apo-E lipoprotein, apolipoprotein E, which is required for the transporting the cholesterol, which is required by the neuron for the synapses formation, for the dendrite formation, and for neuroplasticity. That is also mutated, and with all these factors, they combinedly will increase the processing of the amyloid precursor protein via amyloidogenic pathway, which will lead to development of the Alzheimer disease. Now to talk about tau protein, basically this tau protein's main function is, in the first picture, A picture, tau protein, the main function is to bind the microtubules, and microtubules are present in most of the cells in the body, and their main function is basically either the transportation in the carrying the vesicles, or either functional or structural support to the cells. In neurons, microtubules, they are bind together by the tau protein, right? And the main function is that they carry the vesicles which contains the neurotransmitter, and they take this neurotransmitter to the synaptic vesicles, to synapses, synaptic cleft, where the main function of the neuron takes place. So what happens when the phosphate attached to the tau protein, when it gets more power by with hypophosphorylation, it gets detached from the microtubules. Due to this, microtubules cannot maintain the integrity, they loosen up themselves, and neuron vesicles will not travel to the synaptic cleft. Due to that, there will be not no utilization of the neurotransmitters. And finally, this will hyperphosphorylated tau will form the neurofibrillary tangles. Now, like in recent advantage, more research is going on for the as we have understood so much about the amyloid beta cascade. So the new studies, they are focusing on the treatment so that this progress of the amyloid beta cascade could be stopped, and it did not lead to the extreme stage of Alzheimer disease. But due to many reasons, this treatment has not been successful, and the treatment which was tried was agents that was targeting amyloid beta pathologies, anti-amyloid antibodies, active amyloid beta immunizations, beta secretase inhibitors, and gamma secretase inhibitors, because they both are the enzymes involved in the formation of the isoforms, and alpha secretase promoters, because this naturally decreases the formation of amyloid beta peptides, and amyloid beta aggregation inhibitors. Second agents they are tried for tau pathology, same, that anti-tau antibodies, active tau immunization, tau aggregation inhibitors, microtubule stabilizers, tau phosphorylation inhibitors. But unfortunately, till date, these approaches, they are ineffective, unsafe, or both. Now, as I just told brief about this, another gene which is involved which is involved in Alzheimer disease development is gene apolipoprotein E, and apolipoprotein E is a protein that transports the cholesterol needed by the neuron for synapse development, dendrite formation, long-term potentiation, and axonal guidance. Uh, ApoE is also hypothesized to affect the amyloid beta metabolism, aggregation, and deposition in the brain. Inheritance of only one copy of ApoE allele results in increased threefold increase in risk of developing the Alzheimer disease, and if inheritance of two copies of ApoE, that will lead to tenfold increase in development of the risk of developing the Alzheimer disease. And approximately 15 this ApoE is present in general population in 15%, and people those with Alzheimer disease, they have 40% carrying ApoE 4 allele. That amyloid beta formation, this ApoE also plays a role in that. These all combine play a role for amyloidogenic processing of the APP. Now, current status of the amyloid cascade hypothesis and treating targeting amyloid beta. There are like other uh, alternate theories also, because there are few researchers, those who are believing that due to multiple failures of the treatment that target amyloid beta in Alzheimer disease, not all experts are convinced that amyloid beta cascade is a correct hypothesis. And what is their alternative theory? They believe that amyloid beta is just a biomarker, a tombstone. It is not causing any pathology. This is not the reason for the degeneration of the neuron. They are just saying that just by decreasing the biomarker or tombstone, this will not stop the progress of the disease or make the disease reversible. This is one theory. And those who believe, for researchers, there are more in number. The larger population that believe, a larger number of population of researchers, those who believe in amyloid cascade hypothesis, they say that the failure of this reason for failure of the trial is that when patient was enrolled in the studies, already there was significant damage of the neuronal death or degeneration which occurred. So that's why these trials could not prove to be fruitful. So according to this, they have proposed that the patient should be diagnosed prior to the development of formation of amyloid beta, so that the this development can be means stopped from progressing. So to next in line is vascular dementia. Second most common cause of dementia, accounts for 20% cases of dementia. Vascular dementia is essentially it is a neurological manifestation of cardiovascular system with decreased cerebral blood flow due to atherosclerosis or infarct or white matter changes or microbleeds. They can be it is not most of the time it is like dementia with single pathology is just an exception. It is not a rule. So in majority of cases, dementia person who's suffering from dementia is having pathology of multiple etiology, like they're having vascular etiology also, Alzheimer disease pathology also, and Parkinson disease pathology also. So there is pure dementia of single pathology is very rare. What the risk factor for vascular dementia is hypertension, smoking, heart disease, high cholesterol, diabetes. This is a comparison between that is fluorodeoxyglucose PET scanning of vascular dementia with Alzheimer disease. You can see that in like in vascular dementia, the cause of neuronal death is vascular cause. That can be infarct, that can be due to narrowing of the blood vessels due to atherosclerosis, that can be due to the destruction of the blood vessels due to the deposition of amyloid beta plaques, that can be there can be other causes, there can be small vessel inflammatory diseases, there can be multiple causes. So exact like in Alzheimer disease, the more involved area is cortical area, right? But in vascular dementia, the area of involvement depends upon the pathology which occurs in the specific vessel. So it can involve both cortical and subcortical. Cortical और subcortical में क्या difference रहता है? In cortical patient there will be more symptoms, cognitive impairment के symptoms ज़्यादा होंगे, और subcortical region में जब भी कोई pathology होगी, you will get more symptoms of motor symptoms. Like in this picture, जो न्यूरोनल डैमेज है वो ज़्यादा सबकॉर्टिकल दिखाया गया है इन वेस्कुलर डिमेंशिया, एंड इन अल्जाइमर्स में जो हमने पहले देखा था, इट इज सेम दैट द पैथोलॉजी लाइज मोर इन द टेम्पोरोपैरेटल कॉर्टेक्स. In MRI, how this picture comes, like this is of a living patient. There is increased severity of white matter hyperintensity in vascular dementia. This hyperintensity is indication of means there is a damage occurring in the white matter of the brain. Vascular dementia and Alzheimer disease, they frequently overlap. As I told you, the large portion of individuals with Alzheimer disease also have comorbid vascular dementia. Overlap may occur due to dynamic relationship between amyloid beta and cerebral vascular integrity. Deposition of amyloid beta in the cerebral blood vessels leads to loss of integrity of the microvasculatures, or they increase the permeability of the blood-brain barrier, hypothetically reduce the clearance of amyloid beta from the brain. In all the dementias, you will get pathology of all the what do you call dementias mixed. Features of vascular dementia, clinical feature will largely depend upon the specific vessel involved, and there will be temporal correlation between the vascular event and the onset of the symptoms. Excuse me. There will be typical abrupt onset can be there, and then there can be step ladder pattern. There can be associated focal neurological deficits with that, and slower cognitive decline. Dementia occurs within several months of stroke. To talk about next is Lewy body dementias. Dementia with Lewy bodies and Parkinson's disease dementia, they are collectively known as Lewy body dementia. and they account for 10 to 15% of all cases of dementia. Only an estimated 20% of Lewy body dementia patients have pure LBD. Approximately 80% of LBD patients will also have pathological feature of other dementias, especially AD. Now, what is the pathology that underlies this dementia with Lewy bodies and Parkinson disease? It is accumulation of the abnormal protein, that is synuclein, that results in the formation of that results in the degeneration of the neuron, which later forms Lewy bodies and Lewy neuritis. The pathological link, DLB and PDD shares pathological link to the abnormal accumulation of protein called alpha synuclein. That is why they are called synucleinopathies, and that is why they fall under the same category. In LBD, for unknown reason, alpha synuclein protein aggregates to form oligomers, eventually turning into Lewy bodies and Lewy neuritis as neuron degenerates. What are the core features of dementia with Lewy body? That is fluctuating attention, concentration, visual hallucination, spontaneous Parkinsonism. This is very important to remember that what is spontaneous Parkinsonism, because it will help us to differentiate between uh, dementia with the Lewy bodies and dementia with Parkinson's disease. And the other suggestive clinical features are sleep disorders, severe neuroleptic sensitivity, low dopamine transporter, repeated falls, transient loss of consciousness, hallucination in other sensory modalities, severe autonomic dysfunction, depression, delusion, and syncope. In Parkinson disease dementia, majority of patients with Parkinson disease, they develop cognitive dysfunction approximately within 10 years of diagnosis of the Parkinson disease. And once the patient is diagnosed with Parkinson disease dementia, there is an increase in morbidity and mortality, mostly untimely death occurring within 4 years of being a diagnosis. As with Alzheimer disease, the beginning of dementia over here also is followed by the mild cognitive impairment to the full-blown dementia. Pathology underlying this is neuronal degeneration and atrophy occurring in the thalamus, caudate nucleus, and hippocampus, that is the limbic system, and it is caused by the deposition of Lewy bodies and Lewy neuritis. The pathology in the limbic region, that is hippocampus, caudate nucleus, and thalamus, it correlates with the severity of the Parkinson disease dementia. Now, how to differentiate between Parkinson disease dementia and dementia due to Lewy bodies? It is though it is an arbitrary differentiation, like person who's having Parkinson disease dementia, he will have motor symptoms before the cognitive symptoms, and approximately roughly there will be interval of 1 year of interval they have kept, that if motor symptoms they are present 1 year prior to the cognitive decline, then that is Parkinson disease dementia. And if dementia occurs at the same time or precedes the motor symptom 1 year before the motor symptom, that is dementia with the Lewy bodies. Now, next hypothesis is Parkinson disease and Alzheimer disease spectrum hypothesis. According to this hypothesis, and as shown in the picture, as I was telling that patients with Alzheimer disease, Parkinson disease, or DLB, they have multiple clinical features, pathological features, and neuroimaging features occurring all together at different percentage in all the cases. So in that case, they consider that they are Parkinson disease and Parkinson disease, Alzheimer disease, they are not separate entities. According to them, they are a spectrum, and Alzheimer disease and Parkinson disease, they lie at both the ends of the spectrum, and dementia with Lewy body, it lies in between the spectrum. Now, the next is frontotemporal dementia. Frontotemporal dementia is as common as LBD. An average age of onset is 50 to 65 years. It is further divided into 4 subtypes. The most common subtype is behavioral frontotemporal dementia. Why behavioral? Name itself is telling that patient will have more of behavioral symptoms. There will be like personality change in a person and primary progressive aphasias. There are 3 kinds. that is semantic verbal primary progressive aphasia, and then logopenic verbal primary progressive aphasia, and NFP non-fluent variant progressive aphasia. Uh, like in semantic variant, aphasia is there. In this, there will be patient will having problem in general knowledge also. Like patient will be having problem in understanding the meaning of the words. Non-fluent, as the name says, the language disorder, there will be not a fluent communication skill or language. In logopenic variant, in this variant, patient have before the onset of cognitive decline, patient have disorder of communication skills and language in logopenic variant progressive primary progressive aphasia. And out of this, the most common is, as I already told, behavioral frontotemporal dementia. Diagnosis can be somewhat complex as the clinical presentation and pathology often overlap with that of other dementias. Frontotemporal dementia can be separated from the Alzheimer disease by due to the absence of biomarkers. Now, behavioral variant frontotemporal dementia, there are symptoms are progressive personality change, disinhibition, apathy, loss of sympathy, empathy, hyperorality, perseverative compulsive behaviors, and cognitive deficits. There will be atrophy of prefrontal cortex on neuroimaging, anterior cingulate, striatum, thalamus, non-dominant hemisphere more affected. In the pathology which underlies this frontotemporal dementia, there is mutation of the tau protein gene, that is microtubule associated protein tau, that is but there is mutation of that gene which results in hyperphosphorylation and removing of the tau protein from the microtubules, which makes microtubules destabilize, and they cannot transport the vesicles carrying the neurotransmitter to the synapses, which results in synaptic dysfunction and neural dysfunction. This I have already explained. Now, mixed dementia, as I was telling from the beginning itself, many patients present with mixed clinical neuroimaging and pathological characteristics of more than one dementia. Dementia with only one type of pathology are exception rather than the rule. Postmortem pathology also reveals the same. Most patients will have more than one cause of dementia, ultimately may require more than one type of treatment. The picture there depicts the percentage of mixed type of dementia is occurring. Now, what is the importance of early detection? As this in this picture, when patient when he develops the symptom and when he comes to the doctor, there is a last picture seeing a old man sitting on the chair. He comes with a complaint of memory loss and cognitive decline. But before that, you see that blue picture in dotted. That is neuron which has been deranged. So at this stage, already irreversible damage has occurred, right? So what is the importance of knowing this? That treatment modality should be started. There should be early investigation, and treatment should be started as early as possible so that toxic amyloid beta formation could be prevented. There are two things in this. One aspect is early diagnosis. Early diagnosis, we are still quite good at that, because as shown in previous pictures, deposition of amyloid beta can be clearly seen with the PET scan. In previous pictures I've shown, again I will show you in the next pictures. But even though after diagnosis the treatment is not successful, so as this pathology of plaque formation and neurofibrillary tangle, they result in neuronal damage. So then the main modality of the treatment becomes symptomatic treatment for the betterment of the patient, for betterment of the caregiver. This is for early diagnosis. A is a normal picture, person without any cognitive impairment, not even mild cognitive impairment, and the B picture that shows yellow depositions is of deposition of amyloid beta plaques, which results in neuronal damage. This can be find out early in the stage, and we need treatment modality at this stage. Not even this stage, before that, that the cascade of amyloid beta formation could be stopped. Overview of the treatment for dementia. Till date, only one type of treatment modality is approved, that is symptomatic treatment for cognitive and memory decline. And this treatment do not halt the progressive march of neurodegeneration. Not disease. This is not disease-modifying treatment, as hopes fade for the early development of treatment that can prevent or halt or reverse the Alzheimer's disease. New drug development have moved back to treating the symptoms of dementia to improve the suffering of the patient and to reduce the burden of their caregiver. Now, now we are on the treatment part. Targeting acetylcholine for the symptomatic treatment of memory and cognition. Because in degeneration of the cholinergic neuron is thought to underline a part of earliest symptom of memory disturbance as MCI progress to dementia and Alzheimer's disease. These are the normal cholinergic projection which regulate the memory function in the brain. The picture here depicts that the cholinergic neuron, their cell body lies in the brainstem, that is neurotransmitter center. From there, it projects to the thalamus, hypothalamus, amygdala, hypothalamus, basal forebrain, and to prefrontal cortex. And next picture, from there, another cholinergic projection of which regulate the memory projects from the cell body lies in the basal forebrain, and the projection goes to prefrontal cortex, amygdala, and the hippocampus. They all are, both the cholinergic pathways are important. They play important role in memory. Like in normal person, this picture shows that when a person is having normal cognitive function, their basal forebrain, from the previous picture we can see this, that's neurons which start from basal forebrain, their projection goes to hippocampus and neocortex. This orange circle shows, and this orange line that shows that the presynaptic neuron is normal, healthy, and the circle shows that the neurotransmitters, those are postsynaptically available, they are also adequate, which results in normal cognitive function. This is a normal person with a normal cognitive function. And in this picture, due to the deposition of plaques and tangles, there is degeneration of the neurons in the basal forebrain. These degenerated neurons, that is dotted lines, these are presynaptic neurons. They are generated. This occurs in the initial stage. Beginning mein hota hai ye. And the dotted circle, they still depict that the postsynaptic neurons, postsynaptic receptors for the acetylcholine are still viable. So if we provide acetylcholine here or prevents its metabolism by the enzymes acetylcholinesterase and butyrylcholinesterase, we can still improve patient's memory with the acetylcholinesterase inhibitors. This is what I was telling, that when acetylcholinesterase inhibitors are given, they prevent the metabolism breakdown of the neurotransmitter, that is acetylcholine, by the acetylcholine esterase and butyrylcholine esterase. वो मेटाबॉलिज्म उसका नहीं होने देते, ब्रेकडाउन नहीं हो रहा, तो उसका जो है acetylcholine का लेवल बढ़ गया है. This happens in moderate to severe stage. When plaques and tangles, that is pathology, it extends from the basal forebrain to hippocampus and neocortex. This is the extreme stage when there is severe cognitive dysfunction occurs. But at this stage also, we are not left with any much of hope other than providing successful approach at this stage is stopping the further destruction of acetylcholine with acetylcholine inhibitors only. This approach sometimes enhances the memory, but more often help to retain the current level of memory, thus slow the decline of the memory. Now, to start with a drug that are effective in this, that is donepezil to begin with. Donepezil is a reversible inhibitor of acetylcholinesterase, and acetylcholinesterase is present in both the central nervous system and in the peripheral system in the gut. And this donepezil, it is inhibitory to both the central nervous system neuron and peripheral on the gut neurons. So by inhibiting the acetylcholinesterase, there is increase in level of acetylcholine, which improves our cognitive function. This picture depicts as there is increase the donepezil increases the acetylcholine level in gut also, that is responsible for the GI side effect. When we mostly in our practice we are prescribing anticholinergic to the patient, what are the side effects? Like there is dry eyes, blurred vision, decreased motility of the GI system, constipation, urinary retention. So when we are giving increasing acetylcholine in GI system, those symptom will vanish. Opposite to that will happen. There will be what increased motility, nausea, vomiting, diarrhea can be there, right? So, but these symptoms are transient. Donepezil is safe to dose, and it can start at 5 milligram and can maximum dose is 10 milligram. Now the rivastigmine is a second drug and is pseudo irreversible inhibitor, means it reverses its effect after few hours. And but difference between rivastigmine and donepezil is that it is inhibitor of both the enzymes acetylcholinesterase and butyrylcholinesterase, which is present in the glial cells as shown in the picture on the extreme right. So theoretically it says that as it is inhibiting both the enzymes, there should be more increase in the number of acetylcholine, because donepezil was inhibiting only one enzyme, but in efficacy and uh, efficacy of donepezil and rivastigmine is same only. There is not much of difference. Uh, Rivastigmine blockade of the butyrylcholinesterase in glia may also contribute to enhance the acetylcholine level. See. Now, what is more important is when neuronal damage occurs, uh, and the acetylcholinesterase is mostly present in the neurons. And those neurons, they are not degenerated, and they are further go to for the gliosis. But the glial cells, which are present on the side of the neuron cell, they are still viable. There still butyrylcholinesterase is available, and whatever acetylcholine is available, it is metabolizing that. So in later stage, this is quite, rivastigmine is quite useful that it inhibits the butyrylcholinesterase in the later stage. When gliosis, neurodegeneration has already occurred, gliosis has occurred, but the remained acetylcholine is all means वो भी इसको break down कर रहा है, butyrylcholinesterase को भी जो बची हुई acetylcholine है. Rivastigmine appears to have a comparable of efficacy to donepezil. It may have more GI side effect because because it blocks both the receptors, enzymes, and when given orally due to inhibition of acetylcholinesterase and butyrylcholinesterase in the periphery. There is now due to overcome this side effect of oral rivastigmine, they have introduced transdermal formulation, which results in optimized drug delivery and reduced peak drug concentration. Due to this, there can be less number of side effects in GI side effects. Starting dose for the oral rivastigmine is 1.5 milligram BD, and for patch is 4.6 milligram for 24 hours, and maximum dose can for oral go to 3 to 6 milligram BD and 9.5 milligram on 24 hours with the patch. Next is galantamine. The difference between galantamine with the last two drugs, donepezil and rivastigmine, is that this also have a dual mechanism. One is inhibition of acetylcholinesterase. With that, and it is depicted in the picture, that is positive allosteric modulation. Means it has a two function. Theoretically, with these two functions, like this galantamine, it is acting on the nicotine cholinergic receptors, which are present both on the pre-synaptic neuron and post-synaptic neuron. As it goes and attaches there, it results in more release of pre-synaptic mates, results in more release of what do you call acetylcholine, and the post-synaptic, it enhances the cognitive functions. But this is only theoretically proved, but it has not been clinically proved yet. Starting dose is 8 milligram XL daily, and maximum dose 16 to 24 milligram daily. Now next neuronal pathway, neurotransmitter and its pathway which is involved along with the cholinergic pathway is uh, glutamine pathway. That is also degenerated in the Alzheimer disease. See, this is the picture which is showing the normal function of the glutamine pathway. The first extreme left side, the orange color neuron, and in between the that is in between purple color is the GABA interneuron. This is the cortical part, and then it is extending towards the deeper side, which is showing that uh, the glutamate neuron. Normally in the resting stage, glutamate do not attach to the N-methyl D-aspartate receptor. This is in the resting state when no excitatory neurotransmission has come. That time it is glutamate, it do not bind to the receptor, and the receptor is blocked by the magnesium. This is a physiological process. With the release of excitatory neurotransmission, uh, there is depolarization in the postsynaptic neuron, attachment of the glycine, and with that the glutamate also attaches, which pushes the magnesium from away from the NMD, and there is inflow of the calcium ion, which results in the long-term potentiation, that is learning, memory, neuroplasticity. That means there is development of the synapses, dendrites, and improves the neuronal health. So what exactly happens to the glutamate neurons in the Alzheimer disease? As shown in the picture, that accumulation of plaques and the tangles, it results in the neuronal damage. During uh, that damage where it is going to happen, that cannot be predicted before. But in that damage, mostly the uh, there is loss of interneuron, that is GABA interneuron. GABA interneuron has the inhibitory action on the glutamate. ग्लूटामेट को फायर नहीं करने देता और उसे appropriate टाइम पे ही उसे फायर करने देता है. बट व्हेन देयर इज डीजनरेशन ऑफ द इंटरन्यूरॉन, now the glutamate neuron is disinhibited, so it is continuously firing. So there is availability of glutamate at the postsynaptic neuron at the continuous state, because this has disturbed the normal resting physiological function of the glutamate. This results in the continuously opening the NMD channel, influx of calcium postsynaptically, initially, which will result in memory problems, like when patient present with difficulty in remembering the names, correct word, or where they have kept the things, or difficulty in concentrating. If this continues for the long time, there is difficulty in learning new information, and in extreme stages there are enzymatic process which will take place in the postsynaptic neuron, which will result in the production of the free radicals, and as you all know, free radicals means they will damage the neuron. This will result in the neuronal damage. Mementin Mementin is NMDA antagonist. It is non-competitive and low affinity NMDA antagonist. So the function of this mementin is it it removes the magnesium, blocks the receptor, and tries to bring the postsynaptic neuron at the like physiological try to bring the neuron at the physiological state of rest. तो मतलब रोक देती है उसे कर्व को, resting stage पे ले आती है, due to which these increased calcium influx and the resulting symptoms are not present then. One more thing to remember in mementin is that mementin, as I told you, it is a non-competitive low affinity MDA antagonist. If with this medication, with NMDA antagonist, if it continuously keeps the NMDA block, then there will be no learning of new information or any memory, and patient will be like negative symptoms of psychotic phase, like apathic type. Okay, so then how to overcome that? Because of this reason, it is non-competitive low affinity antagonist, right? That is, mementin is not so powerful a blocker of NMDA receptor, that it stops all the neurotransmission at the glutamate synapse. When there is a phasic burst of glutamate, there is transient release of glutamate which causes depolarization, and that is capable of reversing the mementin block. So what will happen with this if जो पहले ये रोकता है that mementin is stopping the tonic excitation. This is phasic excitation which ये जो allow करता है, right? So with this it helps in learning new things, forming the new memory and neuroplasticity. One more thing to remember in mementin is this is the reason that mementin does not have a powerful psychometric action which is exhibited by the more powerful NMD antagonists such as phencyclidine ketamine. वो psychosis कर देते हैं ना, ये उस level का psychosis नहीं करता है because it is non-competitive and low affinity NMDA antagonist and does not shut down new learning or ability of normal neurotransmission to occur when necessary. But just 2-3 slides for on behavioral symptoms of dementia. These are very common symptoms, and the symptoms are like apathy, disinhibition, sleep, psychosis, agitation, aggression, depression, and anxiety. How to manage these symptoms is because these are the presenting complaints of the patient. These are the foremost complaints with which patient comes to us, and there is no specific guidelines to how to treat the patient in this. There is only study-based treatment. The foremost treatment we should try is non-pharmacological management, like patient, those suffering, a patient who's having impaired cognition, they're having impaired language communication skill, impaired abstract ability or comprehension. They will find difficult to explain that they are suffering from pain, hunger, or constipation. So their unmet needs should be taken care for foremost, and then identify, modify environment stressor, modify daily routine stressor, caregiver supporting and training, behavioral modification, group individual therapy, problem solving, distraction, avoid behavior triggers, increase social engagement, relaxation technique, and music therapy, aromatherapy, and pet therapy. Evidence-based therapy is only music therapy, which has been recommended by the NICE. In pharmacological measurement, as I told, the first line of treatment is non-pharmacological, and analgesics plays an important role in this because patient with abstract thinking problem, they find difficult to means put their complaints that they're having pain. So the assessment and effective treatment of pain is important. Even if people without overt pain, a trial of analgesic is worthwhile with paracetamol basically. And in antipsychotics, initially second generation antipsychotics were quite frequently prescribed, but with the usage of antipsychotic, they have seen that the mortality rate is also high, and there is poor tolerability and effect size is small. That's why they have declined the use. But because of various studies, they indicate that we can, if the patient is we are not able to manage the patient with non-pharmacological ways, patient with severe, moderate to severe symptoms can be managed with low dose and short course of olanzapine, quetiapine, risperidone, amisulpride, aripiprazole. Quetiapine is preferred wherever there is more motor symptoms like Lewy body dementia and Parkinson's disease because it causes less of motor side effects. Benzodiazepines as hypnotics should be avoided in elderly patients because they are already they can decline the cognitive function and they can increase aspiration pneumonia, fall, hip fracture. But in practice, we use low dose, short acting should. If you feel that you want to use, then Z drugs can be preferred. Otherwise, short acting like lorazepam can be used with a lower effective dose, or antidepressant like trazodone can be used like on low dose like 50 milligram. An antidepressant only to be used if patient is having severe, moderate to severe clear mood depressive symptoms, and the most studied is SSRI in this because it is having less of cardiac side effects. Sorry, sertraline, I meant to say. Mood stabilizers, though they are effective in patient, but they should be avoided because of the side effect profile. And recommendation, limited evidence to support use. Use may be justified where other treatments are contraindicated or ineffective. Sodium valproate should be avoided. Melatonin and sleep disturbance. In sleep disturbance, first we should try that non-pharmacological way, that is sleep hygiene. And melatonin can be tried, but there is no convincing evidence that it is very effective. As I told, that trazodone can also be tried. In sedation, antihistamine, promethazine should be avoided because it is already anticholinergic. If there is a need to use this, it should be of short duration only. And in summary about this behavioral symptoms, first non-pharmacological treatment should be tried, and if patient is not we are unable to improve with that, then we can try the pharmacological treatment with with this already told modalities, with the minimum effective dose for the shortest period of time, maximum up to 6 weeks they recommend. These are my references. Thanks.